I'm Nivi. I'm one of the PGY2s. So today I'm going to talk about precipitous and difficult deliveries. This is for those of us who have a healthy fear of babies delivering in CCT. I'll review signs of imminent labor, pertinent history, and physical exam that we should be getting, management for uncomplicated deliveries, and then management and maneuvers we can use for complicated deliveries. So precipitous deliveries, although deliveries are not common in the ED, it is within our scope of practice to be able to help women who are in labor. This is especially true for those of us who end up in community or in standalone EDs where OB-GYN isn't readily available. So women who present to the ED in labor, there's various reasons, including they may not have had prenatal care, they're uninformed about which hospitals provide gynecologic care, unaware or concealing a pregnancy, or they may not have had time to get to the hospital they're originally seen at. Precipitous deliveries are labor that results from lasting less than 3 hours. Common complications to be prepared for include shoulder dystocia, umbilical prolapse, and breech delivery. So signs for imminent labor include a woman feeling imminent delivery. She's already pushing, bloody show, which is a bright red blood in the mucus plug, labial separation, and perineal bulge. So if you have a patient who is in imminent labor, it's obviously difficult to get like a full history and physical for that patient. So things to focus on for your history include how far along the pregnancy is, any complications the patient had during pregnancy, if they've had any fluid leak or bleeding up until that point, if they have any fetal movement, and then how frequently they're having their contractions. For physical exam, as long as there's not any profuse bleeding or you don't see a prolapsed cord, a vaginal exam needs to be done to determine effacement, dilation, and station if there is time. In terms of diagnostics, there's not actually too much to be done, especially in imminent labor. Try to place large bore IVs. Draw labs to get the hemoglobin and RH. And then if time permits, you can try to do a quick bedside sono to look for fetal movement, cardiac activity, determine the position of the fetus. And then for those who are not as clear about their prenatal history, the number and possible gestational age. So just quickly to review dilation, effacement, and station. So dilation is the opening of the cervix measured from 0 to 10 centimeters, and you'll use your index and middle finger to measure the distance. Effacement is cervical thinning and drying up of the cervix. So the percentage number is based on an average 3 to 4 centimeter long cervix. So a fully effaced cervix it'll feel paper thin, and that's what we call 100% effaced. And that's probably what you would see if a patient comes in imminent labor. Station and distance is the position of the presenting fetal part in relation to the ischial spine. So +3 station is impending labor, and then +4 to 5 is crowning, which is, again, likely what you would see if they're coming into the ED. So management for uncomplicated labor. So just as a reminder, actual to the prior birth, the labor can be divided into the latent phase, which is where the cervical mucus plug passes, and there's a slow dilation from 0 to 6 centimeters. After that is the active phase, which is likely where you'll be seeing the patient, which is a rapid dilation from 6 to 10 centimeters. If there is time, things to prepare for birth include calling services that are available, including OB, NICU, and pediatrics, placing the patient on IVO2 monitor, prepare suction and airway equipment for both the mother and the infant, and get the infant warmer. And then if you have enough people, dividing the team into a maternal team and an infant team, get PPE, and then position the patient into a dorsal lithotomy position. So just going through sort of the basic steps of labor. So first you'll look for, do a perineal inspection, looking for the infant's head bulging in the perineum. If you see it, you can start doing a digital stretch with a lubricated finger to help prevent perineal lacerations. And then as the head is bulging, you're gonna support the perineum with a sterile towel and place your hand over the occiput of the fetus to promote fetal head extension. You're gonna wanna slowly deliver the head. Always check for nuchal cord. If you do see it, put your finger in between the nuchal cord and the infant's neck and try to displace it over the infant's head. If you are not able to do so, you will clamp and cut the cord so you can deliver the infant. After this, you're gonna deliver the anterior shoulder. So placing your hand on both sides of the head and giving gentle downward force on the shoulder. And then followed by the posterior shoulder, which is keeping the hands in the same place. You'll apply pressure upward on the posterior shoulder. And then you'll try to do a controlled delivery of the rest of the body to help prevent perineal lacerations. Once the infant is delivered, you'll cut and clamp the umbilical cord. Usually you clamp 3 centimeters distal to the insertion of the umbilicus. ACOG recommends delaying cord clamping from 30 to 60 seconds if the patient and the infant are stable. If they are stable, you can hand the infant to the mother for like skin to skin right after. But if either infant or mother are unstable, hand the infant to the infant team to help resuscitate the mother if needed. So don't forget, after birth, you are gonna have to deliver the placenta as well. So just maintain suprapubic pressure and provide gentle traction on the cord and allow for placental separation. You'll know placental separation happens when you see cord lengthening, a sudden gush of blood, and then cephalid migration of the uterus. And then things to think about: within 1 hour of delivery, there's the highest likelihood for postpartum hemorrhage, which is considered 500 cc's or more of blood loss. So if the patient does start to bleed, first-line at-need treatments to think about include uterine massage and oxytocin. So onto difficult deliveries. So first I'll talk about shoulder dystocia, which is typically where there's anterior shoulder is impacted behind the symphysis pubis. The turtle sign is typically what we talk about in looking for dystocia, where the fetal head retracts against the perineum after it appears. Complications for the fetus include nerve injury, clavicular fractures, acidemia, and asphyxia from inadequate respirations or if the umbilical cord is compressed. And then the mother can suffer from postpartum hemorrhage and 3rd and 4th degree lacerations. The helper mnemonic is something that can be used to help assist like remembering the maneuvers for shoulder dystocia. So including calling for help, emptying the bladder, and then multiple maneuvers, which I'll talk about now. So first is the McRoberts maneuver, and this is where you're having the mother lay flat on her back with her legs flexed to the lateral abdomens. This helps rotate the pubis symphysis, and then you can apply suprapubic pressure while the patient is in this position. These two maneuvers together is successful in about 90% of the time in helping deliver a patient with shoulder dystocia. You can also do the Gaston maneuver, which is where the mother is on all fours, and you apply gentle downward pressure on the anterior shoulder, or actually it's the posterior shoulder, excuse me. And this helps increase the pelvic diameter and then also helps dislodge the shoulder. More invasive maneuvers include the Rubin maneuver, Woods corkscrew, and Barnum. In the Rubin maneuver, you're going to place your finger on the posterior shoulder and rotate the shoulder towards the fetal face. This decreases the shoulder axis diameter. The Woods corkscrew is just the opposite. So you push on the shoulder towards the spine, and this rotates the fetus 180 degrees. You can actually combine both to increase the rotational force to help deliver the baby. And then some of the things I read recommended doing both with the McRoberts maneuver to help deliver the baby. The Barnum maneuver is the most invasive. You actually insert your hand into the vagina with the palmar surface tracking on the fetal chest. And you actually grab the posterior forearm and pull it out. This can be more effective, but obviously is more difficult to do if the patient is not anesthetized properly. For breech deliveries, this occurs in approximately, yes. If you see shoulder, like, yeah. Yeah. If there's 60 seconds pass and the baby's not out, then you have to try to actually the body's going to find a way out. 60 seconds to get back. And then you drop like pressure instead of Okay. Yeah. Mm-hmm. Sure. Dr. Camacho, for those on Zoom, was saying that we have like if you see the turtle sign, you have 60 seconds to essentially start doing maneuvers. And when applying suprapubic pressure, you're going to want to not just apply it, but also do a downward motion with your hand to help actually push the shoulder out of the position it's in. Okay. Breech deliveries, so they occur in 4% of deliveries. Complications include problems with cervical dilation and umbilical prolapse, which I'll talk about in a second. Cesarean section is a preferred method for breech deliveries, but obviously if the labor is imminent, it may not be an option. There's 3 types of breech positions: frank breech, where both hips are flexed and the feet are towards the face; complete breech, where both hips and knees are flexed; and then incomplete breech, where one hip isn't flexed, so the presenting part might actually be the infant's foot. So there's 2 maneuvers I read about for breech delivery. The first is the Marcès-Mélivet maneuver. So for this maneuver, you're going to have the patient in the dorsal lithotomy position. If you do see any cord prolapsing, you can move it 10 to 15 centimeters outwards to help allow some of the delivery to happen spontaneously. And when you allow delivery to happen, and when the umbilicus appears, this is where the maneuver specifically happens, where you place one hand on the abdomen and support the fetal maxilla with your fingers, and you place your other hand on the occiput and actually help with head flexion, which won't happen naturally as it does in a normal delivery. This needs to be done within 10 minutes because umbilical cord compression can occur during all of this. If the patient is in frank breech, you're going to use a Pinard maneuver. Again, frank breech is where their hips are flexed, but their knees aren't. So with this, you apply pressure on the back of the knee and externally rotate the thigh while rotating the rest of the fetal pelvis in the opposite direction. And the point is to help deliver one of the legs. And then finally, umbilical cord prolapse. It's rare, but at 0.1 to 0.6% of deliveries, but there is perinatal mortality rate of just below 10%. Cesarean section is the primary way to deal with this patient. And remember, the cord shouldn't really be manipulated because it can cause vasospasm and then result in fetal hypoxia. So for this, you're going to tell the patient to not push. You want the patient positioned in prone position with her knees to the chest, and then you're going to put the bed in Trendelenburg position. Any presenting fetal parts, you're actually going to manually elevate with your hand, and then the cord should be kept warm so you can apply moist sterile gauze onto the cord. And then you're going to transport the patient just like that to the OR, whether that's in your facility or if you have to transfer the patient. So you're going to be holding up fetal parts until the patient is in wherever OR. Something I read is you can instill 500 to 700 cc's of normal saline into the bladder, and this can actually help lift up any of the fetal parts off of the cord. There's a lot to look at, but this is just I honestly just Googled ways to do precipitous deliveries, and this is one of the graphs I found. It goes through some of the things I talked about in addition to other complications to consider. So I can send this out to people for review. I just want to thank Dr. Turner, Dr. Kopchak, and Dr. Chu. If anyone has any questions, I can take it.